really patently misleading. Thank you. But I would also argue that this formulation of science and politics as inherently in tension with one another is both somewhat inaccurate and a bit misleading in ways that could actually be detrimental to public health. And that actually the idea that they're in tension with one another really betrays certain underlying assumptions about the nature of public health. For instance, sort of downplaying some of the normative components of public health in misleading ways. That we've always known that there are some ethical, and moral dimensions to public health, but also in assuming that data and science speak for themselves and offer clear solutions rather than being sort of partial and interpretive. And, I think we also see in reality many instances where public health has actually been politicized, but in a more health promoting direction, right? So for instance, HIV, which was, sort of my original entry point into public health, was able to secure large amounts of resources and attention through massive social mobilization campaigns, including its attachments to the gay rights movement and a very successful treatment access movement, which secured access to medicines for millions of people. And some people have even argued that HIV has maybe gotten even more attention than it really attention and resources than it deserves, given its overall level of burden. But I think without this sort of politicization of HIV, that probably wouldn't have been the case, right? If it just sort of had remained a kind of medicalized illness. In addition, the ethical dimensions of public health are quite well known. And there are long legacies dating back to at least the 1990s of consideration of how human rights intersects with public health, and an appreciation that data and science alone cannot answer the question of what should we do, right? And furthermore, public health is really almost exclusively a public sector undertaking, and in that sense, really kind of has to engage with politics on some level. Prevention is really notoriously undersupplied by market forces. And I think that there are some normative questions that are raised about whether, if we take politics actually out of public health and just entrust public health to, unelected or unaccountable bureaucrats, is that actually normatively desirable, or is that just sort of turning public health into a technocratic exercise? And could that depoliticization actually undermine certain more positive elements of, like attention to HIV. So given this, I think while there are many good rhetorical reasons to emphasize that public health decision-making is, driven exclusively by science, in reality, the politics of it may be inescapable. It is, in fact, intertwined with politics. So the primary contention of my talk is that the key is to understand how and why diseases become politicized, and that a firmer grasp of how politics interacts with public health can actually be leveraged to improve public health responses. At least that's what I hope to elaborate. But to date, there has been really a growing, but I would say still very limited engagement between public health and political science. Now, this changed a lot with the pandemic, and I'm curious to hear people's thoughts on, how that has evolved during the pandemic. But, prior to the pandemic, there really was not a lot of attention to the politics of public health. There had been a small but growing field of political epidemiology, which is sort of an offshoot of social epidemiology, but with a greater focus on the political dimension. In the non-communicable disease area, there's been growing attention to the so-called commercial determinants of health and trade-related health determinants, which often draw on political science theories such as interest group theory and corporate political activity. And recently, there's been some attention being placed on the growth of what's being called populist radical right parties and political figures like Donald Trump or Bolsonaro around the world, and the potential impacts of this on public health. A really great book recently by Falkenbush and Greer came out on this. And there's long been a vibrant health politics and policy section at the American Political Science Association, and a global health section at the International Studies Association meeting, which is largely a group of international relations scholars that are interested in global health issues. So there are, I think, also good reasons that scholars interested in the social determinants of health, or social epidemiology, or medical sociology, or really anyone for that matter, should be interested in politics, even though it tends to have a very negative connotation. For instance, as illustrated by this quote by Martha Gellhorn, people often say with pride, "I'm not interested in politics." They might as well say, "I'm not interested in my standard of living, my health, my job, my rights, my freedoms, my future, or any future." If we mean to keep any control over our world and lives, we must be interested in politics. So coming back to the title of my talk, politics as a fundamental cause of health inequalities, what exactly is a fundamental cause, and should politics be considered a fundamental cause? So fundamental cause theory, the definition of a fundamental cause was originally outlined by Lincoln Phelan, obviously very familiar names in sociomedical sciences and Columbia. And the canonical definition of it was laid out in their Social Conditions as a fundamental cause of disease. And fundamental cause theory really proposes that some social factors or circumstances remain persistently associated with health inequalities over time, even when other, the diseases or the risk factors or health interventions change, the inequality still persists. And they argue that this is because a fundamental social cause, first of all, influences multiple disease outcomes through multiple risk factors, and also involves access to resources such as knowledge, money, power, prestige, and beneficial social connections that can be used to avoid risks or minimize the consequences of disease once it occurs. And that fundamental social causes endure because the association is reproduced over time via the creation of new intervening mechanisms. So to give an example, so the main fundamental cause that they theorize is socioeconomic status. And to give an example in relation to COVID-19, even though COVID-19 was a brand new disease, and at first, really nobody knew exactly how to respond to it. And actually, initially, we could hypothesize that maybe wealthier business travelers may have been more likely to have been exposed to COVID-19 because they were the ones that were traveling. They may have gotten it first. But as time went on, and as white-collar workers were able to work from home more, the disease rapidly descended the social gradient to affect the working class, essential workers and their households disproportionately. And these effects were also compounded further by decades of structural inequalities that had already contributed to poorer health and greater comorbidities in these same populations, with a consequent compounding of disparities as a result. So even though the disease started off, relatively democratic, affecting everyone, very rapidly as more information came out, groups with more advantage were able to take advantage of that information and structural resources like having being the ability to work from home to mitigate their exposure. And the exposure quickly went down the social gradient to people with fewer resources. So in that way, socioeconomic status, again, sort of demonstrated its fundamental cause characteristics. So while Lincoln Phelan initially conceptualized socioeconomic status as the major or a major fundamental cause, more recently they and others have extended fundamental cause theory beyond socioeconomic status to include other causes such as racism and racial segregation, stigma, and other types of causes, but that they have to have those sort of underlying definitional components. So based on that, can we say that politics is a fundamental cause? So I think one challenge with calling politics per se a fundamental cause is that politics is not one thing, but rather politics sets the context for other causes. So it might be considered a meta cause in that it determines the distribution of resources and power in society. And so I think this understanding of politics is consistent with the classical definition of politics from Harold Lasswell, who summarized politics as essentially who gets what, when, and how, right? So it's fundamentally about the distribution of resources and power in society. And in this sense, we can think of it as a fundamental cause of the causes, or what I'm referring to as a foundational fundamental cause. So it effectively actually determines the social conditions. So politics, in essence, determines the distribution of income in society, the salient racial and ethnic boundaries and cleavages in society, various forms of social stratification, et cetera. So this is my very busy conceptual model, but I'll try to unpack this a little bit. So here we have, the fundamental causes, many of which have previously been elaborated. So, right, we have social conditions, which comprises socioeconomic status, including sort of income inequality in society, maybe various forms of social stratification, economic insecurity. Above, we have this category that I'm calling chauvinisms, which is a French word meaning essentially prejudice or bigotry. And I use that term because I think it's more encompassing of a wide variety of isms that might themselves function as fundamental causes, some of which have already been elaborated, like racism and stigma, but others, maybe, could in the future be elaborated, like xenophobia and sexism and patriarchy and heteronormativity. And then another fundamental cause, which I don't think has been articulated as such, but might be considered one, might be social capital. So social capital is really, considered the grease on the wheel that makes society work and affects levels of social trust. So I'm putting it here as a fundamental cause, but it might also be an intervening mechanism. So for instance, Lincoln Phelan, argue that access to beneficial connections is one of those flexible resources that makes socioeconomic status a fundamental cause. So it might kind of function both as a mechanism and as a fundamental cause. So then we have this more distal group over here that essentially represents certain elements of politics. And so these I'm referring to as foundational causes, or at least the politics part. And ultimately, I'm defining politics as the reigning political economic system. So in the US, we might think of that as a liberal democracy, in that it's sort of based on a capitalist economic system, but with a fairly robust political democracy. But really underlying this politics is this concept of power, right? So the power to determine who gets what, when, and how, right? And so politics is really about the distribution of power in society. So then politics itself largely determines another broad set of what I'm calling institutions that encompass that themselves are then the determinants of some of the fundamental causes. For instance, politics determines the broad social cleavages that are in society. Right. And so in the US, that is the most salient sort of social cleavage tends to be around race. In other countries, it might be around indigenous populations, minority ethnic groups, or religious cleavages. In addition, politics also manifests through ideology and partisanship and determines the different ideological cleavages in society and the party politics that goes into that. Politics is also about competing demands of different organized interest groups and their relative influence on the policy space, right? So we have interest group influence here. And then political institutions include things like electoral laws or the number of veto points to get a piece of legislation passed. And this can really affect the types of policies that countries are able to adopt and how redistributive those policies are. And likewise, countries often have been noted to fall into these relatively stable welfare regime types, including social democracies, liberal welfare states, which is what the US is typically defined as, meaning that it's sort of relies primarily on means-tested programs that are sort of reserved for only the poorest members of society, and corporatist welfare states. And the existence of these kind of welfare regimes exerts, again, kind of a foundational influence on the other types of policies that can be adopted. So all of this, sort of each of these intermediate political determinants ultimately influence policies, which in turn influence other fundamental causes. But I will say that for now, I have avoided putting in any arrows in order to be pretty flexible about how the directions of the relationships might flow here, because I think for any given health issues, the arrow might look a little bit different. But then, of course, further down the line, we have more proximal causes like health behaviors, health systems, genetics, and then with emotions and attitudes playing a kind of intermediary role. And then ultimately, of course, health outcomes and inequalities in health outcomes. So that was a lot to take in. But in order to kind of make some of this a bit more concrete, what I want to do with the rest of our time is to talk about how a recognition of politics as a foundational fundamental cause of health inequalities can actually help us to improve evidence-based policymaking instead of just seeing politics as in tension with public health. And I think there are three ways, maybe more, but three ways that I will outline with some concrete examples in regards to how this understanding of politics might improve public health. So first, I think an understanding of politics can permit us to move even further upstream by addressing the fundamental causes of the causes, the foundational causes that I outlined. Second, an understanding of politics can allow us to use our knowledge of how party identification and ideology affects health behaviors in order to better frame health messaging and address some of the polarization, hopefully, in health behaviors and attitudes that we are seeing. And then thirdly, a better understanding of politics can assist us in improving policy design in ways that can reduce unintended consequences from policy. So basically helping us to make better policies. On the first point about how this can help us to move upstream, I think it's maybe not so surprising that party ID and ideology might affect health policies that in turn affect health behaviors and outcomes. We're pretty familiar with how party ID might, or different legislative composition might affect the adoption of certain policies, right? And so this has been found to be a significant determinant of the adoption of a number of health policies, including, for instance, the implementation of the Affordable Care Act, which was obviously implemented in a highly partisan way. Blue states pretty much adopted the Affordable Care Act on time. Red states, have been dragging their heels in adopting the Affordable Care Act. Likewise, we've seen this with the Children's Health Insurance Program. more liberal states are more likely to be more generous in their children's health insurance program than more conservative states. As I'll mention in a second, anti-smoking policies, tend to be adopted more vigorously in more liberal states than more conservative states. And of course, recently with COVID, the extent and timing of state adoption of COVID-19 mitigation strategies has really been almost a purely partisan undertaking, right? So the liberal states have been very aggressive in adopting very strict COVID-19 mitigation measures, and conservative states have almost gone to the opposite extreme of trying to, sort of ease up restrictions, arguably prematurely. So we know that party ID can directly affect policies, but I would argue that fewer studies treat politics as the underlying driver of health outcomes via policies, right? So usually people are just looking at, how does the policy affect the health outcome, but not sort of linking that back to, okay, if the politics affects the policy, then really it's politics affecting the health outcomes at the end of the day. Although I think people are seeing this more clearly with COVID-19 now. So just to give an example from a previous study I did looking at state smoking and tobacco control policies in social science and medicine. So what I was trying to look at is, first of all, like most studies, I was looking at, well, what's the effect of state tobacco control policies on smoking prevalence? And, I think a lot of studies basically try to tease out the effect of, a given policy, like if we raise the tax on cigarettes or if we adopt indoor air restrictions, is that going to drive down smoking prevalence, right? And so they're trying to tease out the causal effect of the policy on health. And in fact, usually these types of studies see the fact that states select into policies due to their political orientations as a source of confounding. Right? Because what you're trying to do is essentially assign the policy at random, like you would in a clinical trial, and then see, okay, what is the effect of this policy on the health outcome? And, there's good reasons to do that, to try to sort out, the causal effect of it. But what I sort of argued in this paper is that if politics actually causes the policy choices, then shouldn't we think about politics as actually being sort of the fundamental cause of the health outcome, and policy is really just the mediating mechanism in between. The underlying cause is actually politics, right? So we can, if we put in sort of state political context, which then affects policy adoption, the adoption of the policy itself is really more just a mediating mechanism between politics and the outcome itself. And so and this is sort of premised on the fact that we already know that from previous studies that that smoking, excise taxes and indoor air restrictions are effective policies to reduce smoking rates. But what I wanted to look at was the partisan differences across states in adoption of anti-smoking policies, and then whether policies were sort of playing a mediating role between the politics, the underlying cause of politics, and the ultimate outcome of smoking prevalence. And so what I found was that, indeed, liberal states were much more likely to adopt, high cigarette excise taxes over a 15-year period, as well as much more likely to have adopted state indoor air laws and, at an earlier starting point. But consequently, what I found was that most of the effect of taxes on smoking declines was observed within liberal states. So most of the actual progress that we've made on driving down smoking rates in the US was largely driven by these blue states that have adopted these, sort of more aggressive anti-smoking policies. So what this sort of caused me to think about was, okay, so if we step back, maybe really the logically prior question is, why do politically conservative states seem to favor policies that are harmful towards public health, and why are more liberal states more likely to adopt these policies that are more beneficial to public health? And even more, deeply perhaps, what causes some states to be more politically conservative than others in the first place, right? So the point of this illustration is really just to show how, if we sort of incorporate politics back in, this helps kind of move our thinking further upstream. So it's not just about, is a state adopting a policy, but why isn't it adopting a policy? And then what can we do? How, just if we can't actually influence the policy, or maybe we need to move further upstream to figure out, how do we influence those policy adoptions? So, that's the second practical application. That's sort of the first practical application. Second practical application is, how might we use our knowledge of how party identification and ideology affects health behaviors to better frame health messaging? Again, I think while most people might accept the idea that ideology affects health via policies, like we just talked about, there is increasing evidence actually that individual political ideology also affects health more directly via our attitudes and emotions and behaviors. And, in a sense, this is a little bit surprising. And, prior to the pandemic, there was really very limited research on this topic of how individual ideology affects health behaviors. And I think this is at least in part due to the fact that most health surveys don't actually routinely ask questions about party identification or attitudes towards government, right? Like if you look at the Breathes or NHIS, NHANES, none of these health surveys that people sort of routinely use ask questions about party ID. So we haven't ever really looked at the relationship between party identification and health behaviors really until during the pandemic. There were a few studies prior to the pandemic that actually found that conservatives had better health than people who were more liberal, although those studies also conceded that this was partly due to the higher wealth of conservative respondents, and most of the evidence was from Europe, which has a very different political situation than the US. Of course, this changed during the pandemic when all of a sudden studies early in the pandemic, such as this one by Popinski, Guderian, and Albertson, found that partisanship was actually more consistently predictive of COVID-19 attitudes, behaviors, and behaviors than education, news consumption, income, or really just about anything else that they threw into the model. And so just to quote them directly from this blog post, they say that that the politics of COVID-19 are partisan is perhaps not surprising given the condition of American politics, but that mass public health behavior is more consistently predicted by partisanship than by anything else we measured has profound and distressing implications for public health in the coming months. And of course, as time has gone on, more recently, we've seen COVID-19 vaccination increasingly take on a partisan hue. So by early December, we saw an uptick in the number of, or the percent of white Republicans saying that they definitely would not take the COVID-19 vaccine, and hesitancy has come down in just about every other group, except for white Republicans. And as of March 2021, nearly 60% of white Republicans were saying that they would not be likely to get the COVID-19 vaccine. And then more recently, we've also seen that counties with a higher vote share for Trump have seen lower uptake of vaccines, which are contributing to low vaccination clusters and continuing to fuel hospital overcrowding. So what might be driving partisan polarization in health-related behaviors, and why are health behaviors being driven by party ID? So there are some different theories on this. And on the one hand, largely because of conservative science denialism around climate change, there are those who argue that conservatives are essentially intrinsically more skeptical of the scientific community than liberals, perhaps due to inherited personality traits or perhaps due to growing anti-intellectualism tied to this sort of radical right populism. But on the other hand, there are contextual theories that suggest that sometimes liberals trust science more and sometimes conservatives trust science more. And it really just depends on how that issue accords with their underlying value systems. So one of these contextual theories, cultural cognition theory, suggests that people have relatively stable underlying value systems that correspond with certain worldviews. And people perceive risks in relation to these underlying values. And cultural cognition theory basically divides people according to this grid over here in terms of their views on hierarchy versus egalitarianism and individualism versus solidarity or communitarianism. And so liberals, basically in the US context tend to fall in the more egalitarian and communitarian worldview, and conservatives more in the hierarchical and individualistic worldview. I'll share a sort of a recent application that I tried to make of this cultural cognition theory to COVID-19 vaccine hesitancy from a study that I recently undertook. So we collected data from a survey panel of about 1,300 New Yorkers in late November of 2020. And we were looking at vaccine hesitancy attitudes and a variety of other things. But what we found was that, I guess somewhat unsurprisingly, that people who voted for Trump had higher hesitancy, almost twice as much hesitancy as Biden voters. Interestingly, so did those who did not vote or voted for someone else besides Biden or Trump. And that was even adjusting for a number of other controls, including education and income and different confounders. But when we included measures from the cultural cognition, individualism, and hierarchy scale, as well as some measures of distrust in public health institutions, the differences in vote choice basically disappeared. So, once we sort of accounted for differences in people's underlying value systems and their distrust in science or scientific institutions, that effect went away, right? Which would be consistent with this sort of cultural cognition theory. I will note that interestingly, though, adding these same variables did not reduce hesitancy among non-Hispanic Blacks and women, suggesting that other mechanisms may be driving hesitancy in those groups. So I will sort of briefly give some implications of cultural cognition theory for policy and practice, and then I may skip my third point and sort of sum up because we are getting low on time. I think one of the implications of cultural cognition theory and similar types of theories is that simply providing more information to the public, or more accurate information is unlikely to really change people's minds on its own. And that if opposition to COVID-19 restrictions or vaccination is largely derived from underlying and relatively stable value differences that correspond with political ideologies, that this might inform how we can frame different public health messages about COVID-19 to be more effective, actually, in our messaging. So for instance, one example of this where I think the public health community maybe missed the boat, and I'm not like claiming that I have answers or that obviously this was unprecedented, but maybe moving forward, something to think about is that we kind of missed an opportunity to frame mask wearing and vaccines as actually a means of promoting freedom, right? Throwing off restrictive social distancing measures, getting the economy back open. So connecting mask wearing and vaccination to freedom, rather than connecting it to the opposite of freedom, right? And also I think, at least for me as a public health person, my visceral reaction to the message on this mask, worn by force, not by fear, is, to sort of cringe and say, that's horrible. But on the other hand, thinking about it, if that kind of political statement gets people to wear a mask, if they are able to wear the mask, but still be making a political statement, then maybe that's not a terrible thing. Whereas, for liberals, this kind of protect others, protect yourself, that accords more with, egalitarian and communitarian values, that's going to have more impact on liberals, right? So we have to think about how we are framing our messages. Another idea is that, maybe for conservatives, framing, being anti-mask or anti-vax as being a free rider could be a way to sort of frame it in a way that actually would have negative connotations for conservatives. Being a free rider is historically something that conservatives are very against, right? And so actually the popular, welfare queen stereotype was largely based off of a stereotype that painted people on welfare as being free riders, right? As sort of collecting, money from tax-paying citizens that they did not contribute to, right? So you could sort of turn that back around and paint, being anti-mask or anti-vax in that same way. Another point I think is that we missed the boat a little bit in terms of not getting ahead of the narrative in dismissing concerns about the effects of social distancing on the economy and personal finances. I think later on, the public health community kind of caught up to this, and it was conveyed that, okay, the economy would have tanked anyway, right? Even if we didn't do stay-at-home orders and social distancing. In fact, the economy may have even tanked more, because if COVID is uncontrolled, the economy really can't recover. People don't feel safe. There's no consumer confidence. But I think getting out ahead of that narrative would have allowed us to avoid what became a dichotomy that really drove conservative and liberal divisions on the stay-at-home orders, which was that it was viewed as harming the economy. And if we had also, I think, as public health scholars, thought more about the intersections of how economic policy and health policy intersect, that you really can't undertake the health policies we needed to take without providing an economic policy to alleviate some of the effect on the economy and people's personal finances. I think in the future, we really need to better integrate those. So in the interest of time, I'm going to sum up, because I do want to have time for discussion. Let me just see if I can, okay, I'm just going to quickly run to my slides that I wanted to sum up with. So I guess bringing us back to fundamental causes, is politics a foundational fundamental cause? I would say in many ways, yes. I mean, granted that politics is not one thing, as we talked about, but it does influence multiple disease outcomes. We could think of many examples of different disease outcomes that are affected in different ways by politics via multiple risk factors, right? And it very much involves access to resources that can be used to avoid or minimize risk. And the partisan effect or other types of political variables maintain an association with disease, even when some of the intervening mechanisms change. So in that sense, I think it meets that definition. And so just lastly, where do we go from here? I do think that ultimately we need to address the declining trust and the growing polarization in society. And, we've definitely seen from COVID just how fundamentally these underlying, the political polarization in our society can really affects our ability to undertake the public health measures necessary to contain and control disease. So, I think some things that we can continue to research in the future is, examining how to build trust and reduce polarization. One thing that I'm sort of applying for some money to potentially look at is whether messages of economic solidarity increase willingness to redistribute and cooperate, whereas more divisive messages, do they actually undermine economic solidarity and willingness to cooperate. Also, we need to think more about how reducing social inequality and demonstrating that government can improve lives, if that can improve people's perceptions of the government as an actor. Another research study I'm applying for is to look at whether some of the major stimulus approaches that have been adopted during the pandemic, and some of these big bills that infrastructure bills that might potentially pass, whether they improve people's perceptions of government programs and offset some of the negative harms from the economic downturn, like substance abuse and mental health issues during the pandemic. So I'll leave off there, but I welcome any feedback, questions, comments, and this was a food for thought talk, so feel free to push back. And, yeah.
Thank you, Ashley. Let me just say, really excellent and incredibly thoughtful. Complex questions and potentially very clapping hands on the squares, very complex research questions to ask as well. I want to take questions, and either you or I can snag people having questions. And if there's 2 minutes at the end, you can give us the final conclusion on schools that we didn't get to see. I know that would have been interesting for us to see, so I'm sorry about that. Questions or comments, anyone?
Sharon, looks like has a question.
She's either clapping or has a question. There she
was a question. Hi. Well, thanks very much. First of all, I just want to say this is one of my favorite series of talks always throughout the School of Public Health. And I found this talk like equally compelling and interesting. I thought it was great. One question I had though was about linking this to the larger fundamental cause framework, and whether or not it was necessary, and if in some ways it undermined some of what you were doing. Because one of the major things of fundamental cause approaches, especially as it was originally expressed by Lieberson in his notion of basic causes, was that clipping the mediators doesn't do anything. That what you really need to do is get to the basic cause, because it will just be reproduced regardless of the mediators. But your work talks about ways to influence the mediators, to change the mediators. And I think it all makes sense what you're saying, so that I don't know that it's necessary to frame it in fundamental cause. I'm not sure what that helps. Because basically it seems what you're saying is these are drivers of mediators that are important that we shouldn't neglect. So I was just wondering about your thinking about that.
Yeah, I mean, I think it's helpful to think about, but I think really what I'm saying is that, actually we may even see the social causes as the mediators, right? And I mean, so by sort of moving further back, and looking at how politics, actually determines social causes, that, in reality, or even just that we can't really change the social conditions unless we really influence politics, which sort of forces us to go further back, or to sort of move the basic cause even further back.
Right, but again, I don't think you need fundamental cause for that, and that sort of undermines it. I think what it's just saying, fundamental cause, for example, about inequalities would just say, if you don't tackle inequality, it doesn't matter what these mediators are, we're always going to have inequalities in health. And then the question could be, how do you tackle, inequalities? How do you get rid of them? And you always have to go upstream for the intervention on something more downstream. So, but calling it fundamental then would undermine and all your efforts, which seem like policy or interventions on the mediators, because it would suggest that the mediators don't matter. And in fact, if you saw politics as a fundamental cause of SES inequality, and SES inequality is the mediator, calling it a fundamental cause would, it seems to me, undermine the mediation on SES. So I just don't know that it's value added, and I think that it kind of perverts the notion of a basic cause in some way. But all that being said, I think that's just a framing issue, and
Yeah, it's definitely something. I mean, so that's why I sort of called it ultimately a foundational fundamental cause. But I don't disagree that I mean, what do we necessarily gain by? Do we have to attach it to fundamental cause theory, or can we just point out that hey, politics is kind of actually determining the fundamental causes, so we really need to focus our attention at that level. But yeah, that's definitely helpful feedback.
Thanks, Sharon, and thanks for the comments about the SMS series. Anyone else want to comment or have questions? Not normally a quiet group, Ashley. If you could just, go ahead, Christian.
Thank you, Kathy. And thank you, Ashley. That was really, I love the title that it's food for thought, because it's really put a lot of food for me to think about. I'm a new faculty member at SMS, starting officially this Friday.
Oh, wow.
And so a lot of what you've said in your presentation, of course, makes a lot of sense. And maybe you'll get to know me a little bit more later, Ashley. A lot of my work is in the Philippines, my home country. And if you know anything about the politics there, corruption is the biggest problem. Whenever I go back home, think about all of the public health problems, which are normally about everything you can imagine times 100 compared to here in the US. One of the things that I realized, as much as I wanted to avoid it, was if I wanted to make anything happen, if I wanted to make change happen, I would literally have to go through the politics of it all. And frankly, I'm now even considering running for office because I have to be in power to make things happen, which is not really what I want to do now. Do you have any suggestions for these kinds of systems or nations with such a corrupted political system? How do I even begin and where?
Wow. Okay, that's a really big question. I will say, a lot of my work does focus on, low and middle income countries, actually. So I don't, but the talk was more focused on the U.S. context. But I think, moving upstream, the idea of moving upstream and looking at, how can we sort of address these political determinants, that could apply anywhere. But of course, the exact political determinants might be different, right? And so in a lot of low and middle income countries, you have very weak, the state is very weak, and there's a lot of corruption, and there's a lot of additional issues that you don't even, that you don't have as much of in high income countries. So yeah, a lot of what I work on actually focuses on how can we strengthen the capacity of developing countries to basically run better, to run more like Weberian bureaucracies where, it's more governed by rationality, where you might reduce corruption, but, it's a really intractable issue. And, I think it's playing out right now in real time for so many people with, vaccine distribution and supply chain issues and the weak supply chains in developing countries. And yeah, happy to, discuss more about it with you at some point. But I don't have any ready-made answer, this is how you can solve all the problems of your country.
Well, thank you very much. And yes, I will follow up. I will take you up on that invitation. Thank you.
Wonderful. Thank you.
Thanks, Christian, for maybe asking a really broad and important question to just challenge Ashley a little bit at the end. So I think I don't see any other hands for pressing questions. And Angela, go ahead. And obviously, if people need to leave, they should leave. And Ash, can you stay a few more minutes?
I can stay. Yeah, I can stay.
Okay.
Hi, Ashley. Just really quickly, how does your conceptualization and model really relate to the WHO approach, which is even more, to fundamental causes down to intermediary causes as points of intervention? And, I'm motivated a lot by my conviction that housing is a place to begin. Housing is a strategic point where all these things, politics, down to SES, down, race, ethnic discrimination, the isms in various ways make a difference. And so that's something that is a point of intervention that something can be done about. So I'm just wondering about that relationship with the WHO work on this, trying to really address really what you're talking about as well too. There are these broader macro that sets the context for all of it, right? But how do we definitely, intervene? What's the point of intervention, both prevention and remedy, if you will.
I'd have to look back at the, I think, are you talking about like the WHO social determinants of health, like framework?
Yeah, there are a number of things that have to do with and strategies for action. It's the frame, it's the social determinants kind of division, and then there's a particular publication, a number of publications on strategies for action that talk about this notion of intermediary determinants of health. And I think that also is responsive to Sharon's kind of notion as well too.
Yeah, I'll have to look at that more closely and how, they sort of correspond or overlap or where the points of differentiation might be. But yeah, I think housing, definitely, I would kind of maybe put that in the policy box there that, like politics affects policies, including housing policies, which is, a critical determinant unto itself of a variety of different health conditions. But again, sort of the politics is really what is determining housing policy, right? And so that's really where we need to intervene. And in housing policy, I think there's this overriding notion that, at least in the US, that markets, need to determine housing policy. And there's never been a really strong push for socialized housing or, highly subsidized housing. There's a lot of policy debates, right, about housing policy, but they're all political debates, right?
Absolutely, but there's also the notions of racist behaviors and attitudes and fears on the part, discriminatory. Yeah. It's not just race. It's based on ethnicity. It's based on perceptions of who's desirable not to be in our neighborhood, to kind of affecting the schools and all of those kinds of things, which are there's policies against it, but in fact, how it operates, in fact, is kind of a determinant also. Just to comment as much as anything, not to move you into the WHO model. But
Thanks, Angela. Let me just jump in here a second. Tracy has a question, I believe. Is your hand up, Tracy? And then we'll wrap with your question.
Hi. So I thought it was real interesting how you drew like politics and down to the state level and conservative versus liberal states. But I was wondering if you had any thoughts about how politics intervenes in institutions, for example, like the NIH, which guides biomedical research for our country, and how politics influences institutions like that as research, giant policy research agendas, like say the All of Us cohort, the Precision Medicine Initiative, and how that trickles down to actually, health outcomes.
Yeah, I would definitely have to think about that a bit more. Obviously, the NIH is a major government institution, and the decisions about how much funding to give to the NIH, and how much emphasis to put on certain health conditions versus other health conditions, that ultimately affects what gets researched, what doesn't get researched, which can ultimately affect health outcomes. I think any of us that have ever applied for an NIH grant as a social scientist knows that we only have a few places that we can actually apply. And, I think that says something unto itself about, how we value social science research on health, and, ultimately, then whether we're going to have the research that we need to influence health outcomes in the way we need to. And, maybe part of the problem of why we don't really know how to address vaccine hesitancy and some of these more social issues is we haven't invested in the research in it in the same way that we have for, biomedical interventions, for instance. But I will definitely think about that a little bit more. It's just my off the cuff response.
Thanks for the question, Tracy. And Ashley, thanks for the plug at the end for social science, of course. We all need
always happy to plug social science.
So really, it was just a real pleasure to have you with us today for this presentation and conversation. And just to say again, Ashley is technically around as a visiting professor this semester. So if ideas sort of cook up about other ways that Ashley could be working with us, please reach out to her or to me and we can go from there.
Yes, please do. And thanks so much, everyone, for coming. It's great to see you.
Terrific to see you, Ashley. Okay, we'll stay in touch.
Yep, take care, everybody.
Thanks, everyone. Appreciate it.